Ni hao, good morning. Dear professors, administrators, ladies and gentlemen, may I share my presentation? Okay, it's my pride and privilege presenting at the International Conference on Recent Advances in Precision Medicine and Population Health, organized by NHRI and Pyongyang General Hospital. This photo is from November 2019 with my dearest friend Davo during my visit to NHRI, together with his research team and international students. So, as mentioned, today I just want to talk about joint cartilage regeneration, because if cartilage is degenerated, we call it also osteoarthritis, that's a big population health problem. And precision medicine, or also personalized medicine, can be an effective tool to overcome this problem. So, as a medical doctor, I'm an orthopedic surgeon, and I work in the sports medicine department, so we see a lot of sporting people. Our first intention is to do no harm to our patients, which comes from the Hippocratic Oath. So what has changed from precision medicine towards personalized medicine can be summarized in 3 headings. Now we have better biomedical imaging tools, including MRI and ultrasound, that I'm going to mention. And then we also have more better molecular imaging platforms, and of course genetic sequencing. Then we have the tool of nanomedicine, and we have also bioengineering facilities where we can use all this technology in our patients to treat the cartilage problem. So I just want to start with a sporting event. This is an ultramarathon somewhere in France, in Chamonix, I guess. That's the celebration of the end of the race. So some of you may not know what an ultramarathon is. About 2,300 athletes come together at 6 a.m. in the morning. They have to run 171 kilometers, which is 4 times more a regular Olympic marathon. They have to cross 3 countries, and if they cannot complete this race in less than 46.5 hours, they will be disqualified. That's more to add, the altitude of the race begins at 2,500 meters, and they go higher and lower. They of course start in the very early in the morning, but they have to run through the night, wind, cold, rain, and sometimes snow. So their creatine kinase levels, which is like in me it's about 800, increases up to 100,000 or 200,000 after the race. So this type of extreme sports has a huge impact on the human body. So actually what I just want to mention here is that we always admire a starfish because when it loses one arm, it regenerates. But the human body also has the same potential of regeneration. For example, the muscles in these runners, they degenerate, like seen in this. For example, this part of the muscle is very normal, but this part is totally degenerated. Here also some degeneration. But this recovers in about 48 hours after such a marathon or ultramarathon race. So this is what we know about the skeletal muscle, but the joint cartilage is very important to us too, because the thickest joint cartilage is in the knee joint. It's about a centimeter or something like that. It has excellent load distribution. It causes some low friction coefficient, and it's durable. So a regular person can live up to 80, 85 years old if he or she does not have a cartilage problem. But in some cases, we miss this potential. So when we look at the joint cartilage from a closer view, this is a histological section. It's a non-vascular, non-neural, and non-lymphatic tissue. So here is the joint space, and all this cartilage nutrition comes from the synovial fluid. And here we have the cells. It's called chondrocytes. It's just one type of cell. In the cartilage, there are 4 layers. And during the 4 layers, the cells of the cartilage are different in shape and size. So is the collagen orientation, and so is the extracellular matrix. So we can focus a little bit more to the extracellular matrix because cartilage has a self-renewing potential, which we call homeostasis. And when we want to treat this cartilage in disease or trauma, then we need to think of biomimesis. So this is the close-up view. Here we have the chondrocyte, then we have the link protein. It's called collagen type 2. So today's in clinical practice I'm going to mention, we can inject into the joint some collagen type 2 for treatment or modify the natural course of the disease. Then we have 2 other components, which is glucosamylglycan and chondroitin sulfate. When you just look at this is the SCM picture of this molecule. It's like a brush, and it contains some water. So the weight of a fresh cartilage, 70% of this is water, actually. So the main aim of cartilage, joint cartilage, is to keep some water inside of it, so all the functions can work normal. This is an X-ray of a young person, of a young athlete, maybe 17 years old. When you look at the cartilage in the lateral compartment, it's pretty smooth, but when you come to the medial, there's some kind of shadow over here. So when we use MRI technology, we can see that here is a swelling of the joint cartilage, including a degeneration in the subchondral bone. So if we do not treat this kind of disease, which is usually after sports trauma, then we will have a case that's called secondary arthritis. This is also a very severe condition. We see it in elderly patients. They come to our clinic with pain, some deformity in their extremities, and loss of function. So here, the joint space is narrow, there is some sclerosis in here, and some osteophytes. So this patient may go to a surgery, but some patients, they want to have no surgery. So that's a big problem. We should keep in mind that it's not only the joint cartilage that's degenerated, but it's also the underlying bone. And the prevalence of osteoarthritis is pretty high. So in an aged population, let's say about 50%, or better to say, 1 out of 2 people will have some osteoarthritis. So it's a pretty high incidence. And as Professor Theo a few minutes ago mentioned, these patients cannot walk. We previously thought that it has some morbidity. So patients have pain, they cannot walk, they cannot do their daily activity. But recently there are some new publications that highlight that the rate of mortality, the number of deaths, is increasing with arthritis-related problems because these patients cannot walk and they lose their health in a non-walking chronic disease. So it's a population health problem, as mentioned. And of course, there's a cost for diagnosis and treatment of these patients. So previously, we had some non-surgical treatment options, like we asked the patients to lose weight, we asked them to strengthen their muscles, then we give some medicine to treat their pain, and of course some methodology used for physical therapy and rehabilitation. And if this was not functioning, we jumped previously to surgery, either focal repair of the problem or joint replacement, to be partial or total. But now, with an aging society, which is a problem all around the world, we have started using disease-modifying supplements. So we provide them some extracellular matrix components orally. They take this as support supplement, and that helps to release their pain. And we also, as mentioned before, we can do some joint injections using hyaluronate. So still we use this technology with some evidence of release of pain, and by these methods we gain some time for the patient until surgery. But now we also use some cellular and molecular approaches. This is moving from precision medicine to personalized medicine, because we take the cells from that patient, and then we, especially stem cells, it could be platelet-rich plasma, it could be stromal vascular fraction, or recently stem cells, and we can apply them back to the degenerated part of the patient. And also recently we are working on extracellular vesicles of cells. Instead of using the cell itself, we can use its components to treat the patient. So these are some new treatment options for osteoarthritis. So as I mentioned, the three main topics, I would like to start with biomedical imaging, and MRI technology is developing and promising. So we recently used the 3 Tesla MRI to measure the thickness of the cartilage. This is the patella and the inferior patellar cartilage. We can measure the thickness very easily. We can do some mapping in here. Plus, we can also look at the signal intensity with a special software, which gives some information about the water content, which is very important for the cartilage function. So we can quantify much more easier the effect of, let's say, exercise or disease in joint cartilage. So this is a promising new technology. Then we also can use ultrasound that I mentioned before. With ultrasound, we can measure the thickness, not the signal intensity actually, but now there is a software called shear wave elastography. So we can assess the speed of sound inside of the tissue. This is not a cartilage, but this is the tendon. So we can get some numerical data on the stiffness of the tissue. So this is also very important for the biomechanical function of any musculoskeletal tissue, which is a promising technology. So we also use medical ultrasound to quantify the disease, and of course, any treatment we apply to the patient can also be quantified with this new technology. And then we have molecular imaging platforms, for example, cartilage oligomatrix protein, which we use in triathletes. They, as you know, do some swimming, then they do some cycling, and then they do some running. And as expected, during running, before and after running, the cartilage oligomatrix protein increases just after the running ends, and just gets back to normal level afterwards. So 3 methodologies for biomedical imaging, MRI, and ultrasound, and molecular imaging platforms help us to monitor the disease plus the treatment that we use for these patients. And of course we have sequencing technology, or recently omic technology, that's very promising, and we use such tools to assess experimentally some information on cartilage degeneration and regeneration. So there is one more topic, that we don't want to use more animal experiments, and instead we use now human organs on a chip. So we developed a joint on a chip, which contains a piece of subchondral bone in here and some cartilage. So we put it into this chamber, and the chamber is of 2 parts. One is the cartilage part, and then we have the bone part. and we just infuse them with, let's say, any medicine or cells or any component we want to treat. So this gives us an advantage to use less animals, less in vivo tests, and use such chips in the future for example, working on new medicine or cellular therapies or whatever we want to do. When it comes to bioengineering, there are some biomaterials that we use to regenerate the cartilage. Usually it's polymeric matrix because we know that it's type 2 collagen. The articular surface of the cartilage is type 2 collagen. Then we can, of course, add some cells, usually chondrocytes, or we can use stem cells, or if we want to mimic the subchondral bone, we can use also osteoblasts. And of course, signaling molecules, or genetic molecules, signaling molecules, can all be added into a cell culture medium that can be afterwards injected into the problematic area. Remember OCD that I showed you, the X-ray and the MRI in the patient. So in young people, we can use such technology to treat the defect. One more important thing in that issue is the number of patents in 2011 was maybe 50% on bone tissue engineering and cartilage tissue engineering. So the bone somehow regenerates itself, but I would like to focus on cartilage because cartilage is still a problematic tissue. For regeneration is restricted. So cartilage is more important than bone regeneration for us in clinical practice. So just to mention that personalized medicine or precision medicine is a little bit different than conventional medicine. Because the person, you cannot find it on a pharmacy, you cannot purchase it. Of course, now we have some allografts or allo cells, but still we use cells of that human to treat the problem of that person. So it's investigational drug exemption in FDA, and it's pre-market approval recently. And the Ministry of Health in our country asks for permission for each patient to use cells. It can be chondrocytes or stem cells, and scaffolds or any active molecules, and the combination of them is all personalized treatment for us these days. What we did as research in nanomedicine was also interesting for us because we tried to treat the problem, the degenerative joint, using mesenchymal stem cells containing injectable alginate hyaluronate microspheres. We like injectable materials because it's easy to apply in an outpatient clinic. So we tried to combine the cells with alginate hyaluronate to inject into the joints of those patients, and these are our, let's say, nanospheres or microspheres, which contains our active molecules. And we did some tests on that. Then we used some medicine to treat the osteoarthritic problems, again with some microspheres for intra-articular treatment of osteoarthritis. So we developed some microspheres, we combined them with some medicine, and then we use them in vitro testing, and then we established our rabbits, some osteoarthritis in our rabbit knees. We did some meniscectomy and some injection of collagenase, and after osteoarthritis was established, we did some injections, and afterwards we assessed the biomechanical hardness of the cartilage. Because the cartilage, to function in a normal way, needs to have some micro-hardness. And we showed that the medicine injected with microspheres was effective in treating the cartilage. So there are some tools to regenerate these type of problems. But we need to use them, of course, in clinical experiments. One other technology that we recently developed was that instead of using glycosamine orally, we incorporated that into nanospheres and combined them with hyaluronan and did some in vitro tests. Now we need to do some in vivo tests, so maybe injective methods will be a very good alternative to treat cartilage problems. And we are also working on microneedle technology. We are producing such kind of microneedles to treat, again, osteoarthritis in a more simple way. Engineering and regenerative medicine approaches is a little bit more complicated. We mentioned about scaffolds and cells. Here, we did some animal experiments to produce new cartilage. Here we have some biopolymers that we implanted into the rabbit knee. So here you see the chondrocytes, and the new implant has somehow integrated in about 8 weeks. So in the future, you may hear such terminology which says cartilage engineering company. I call this as a sashimi, the Japanese food. Like the rice here is usually bioceramic, and here we have the polymer that contains some cells that's also effectively used in clinical setting. So this was our project. We used adipocyte-derived stem cells, combined them with polymers, and then we produced the subchondral bone, including some regulatory factors for union into the tissue easily. Here we see some macro channels for the vascularity of the subchondral bone. After establishing them, we combine them with polymers, and here we have our stem cells, which attached very effectively to the polymer in our research. Here we see the live cells. They are very happy in the environment, but we still didn't do some in vivo experiments. One other technology that's very promising is 3D bioprinters. This is the combined project with our Spanish partners. Here we use some nano ceramics, it's hydroxyapatite, and of course some polymers. But it took us, let's say, more than a year to design the muzzle, because we have to have a very precise muzzle to print some cartilage and of course some bone. We call it the origami project, like the Japanese origami. We established some subchondral bone parts. This is in vivo testing into the skeletal muscle. Here we see the polymers. The polymers had no adverse effects. They were biocompatible when implanted into tissue. So now we look forward to use them in cartilage in the future. So to sum up the technological platforms that we can use, biomedical imaging is very promising. As I mentioned, MRI is a very good platform, and medical ultrasound is also a very good platform. And we also use molecular imaging technology to assess the outcome of our clinical study. Then we have regenerative medicine tools where we use biomaterials together with cells. And for injectable, we can use also nanotechnology in medicine. So these are all promising precision medicine tools or personalized tools that we want to use in the near future. So I started with ultramarathon, and I just wanted to conclude with another form of race. This is more interesting. There is a transcontinental race. The athletes, there are maybe, let's say, 12 to 16 athletes, they do a jogging for 4,500 kilometers. So they cross the continent from one side to the other side. Of course, it's a very severe extreme sports. They have to jog 70 kilometers per day for 65 days. So these patients, I mean, let's say these sporting people were, of course, monitorized. There was two groups, one German and one Korean, South Korean. They used to monitor these athletes by MRI and cartilage oligomatrix protein. And very interestingly, such sports didn't do much harm to the joint but it did some other adverse effects. These marathon runners had a shrinkage in their brains, so they lost also some glial cells, which is quite severe. So I wouldn't recommend to go to extreme sports. Like Professor Theo said, you can do some exercise for 25 to 35 minutes per day, but ultramarathon or longer runs are maybe harmful for your health. I once again would like to thank you very much for your invitation. Here the visit to a research center in Taiwan, and here you see the tower in Taipei. And for further reading, maybe I can refer the Musculoskeletal Research and Basic Science book. And I look forward to meeting you soon again in personal. It will be a very good pleasure for us to be together again. Thank you so much.